Assalamualaikum. I'm Dr. Daniel, Board President from Alifrah My Hospital, Karachi. Today I'll be presenting our unpublished topic on the effects of prostaglandin analogs on SLP. I have no relevant disclosures. This is the abstract. Globally, glaucoma ranks the leading cause of retrovascular blindness, with more than 79 million individuals affected in 2020, and a figure projected to exceed 110 million by 2040. Because optic nerve damage is permanent, lowering and controlling the IOP remains a cornerstone at preventing disease progression. Prostaglandin analogs are the most commonly prescribed first-line topical treatment. They effectively lower the IOP by enhancing the uvascular outflow. However, many patients struggle with long-term adherence and therefore limits sustained control. In the search for effective non-pharmacological option, SLT has been increasing prominence over the last few years. Its short, low-energy pulses selectively target pigmented trabecular visual cells, producing minimal structural damage as compared to its predecessor, ALT. As SLT use expands globally, understanding how commonly used medical therapies, particularly the prostaglandin analogs, interact with SLT for lowering IOP. This single-centered prospective cohort study aims to evaluate the relationship between concurrent prostaglandin analog use and SLT outcomes in patients with primary open-angle glaucoma, specifically within our population. Our study was a single-center prospective cohort done at the Hashwani's Group of Hospital, Karachi, from January 2023 to July 2024. We did non-probability convenience sampling for a sample size of 69, which was calculated using Cleveland Clinic online sample size calculator with the following parameters. IOP measurement was done pre-SLT on post-SLT day 1, 7, and 13. Our statistical analysis was performed on XPSS version 26. GP grid test analyzed the normality of quantitative variables, and baseline characteristics were assessed by CAS-square for categorical variables, while independent t-tests and random tests for continuous depending upon the distribution pattern which was noted. Post-SLT IOP changes were non-parametric and therefore were analyzed by repeated meshes analysis and represented as median with interquartile ranges. Multivariate regression analysis was applied, and a p-value of less than 0.05 was considered statistically significant. We included patients from 20 to 80 years with primary open-angle glaucoma and 360 degrees of grade 3 or higher angles on gonioscopy according to the Schafer's classification. Based on IOP of 18 to 35 mm per grade, we divided them into two groups. The prostaglandin analog users, which were people who were using two prostaglandin analogs for the past 2 weeks prior to SLT, while non-prostaglandin analog users who did not have any use of any history of prostaglandin analog use or discontinued the prostaglandin analogs for more than 3 to 5 weeks. We excluded patients with intraocular history of intraocular surgery, laser treatment preceding including the SLT preceding 3 months, while ALT at any time, or secondary glaucoma, retinal dystrophies, or retinopathy. To summarize my results, this is the baseline characteristics. 79 eyes from 45 consecutive patients were included, which then there were no loss follow-up or withdrawal of consent, as can be seen from the graph and the table, that the only statistically significant difference between the two groups was pre-SLT IOP and pre-SLT anti-glaucoma drugs. This means that both groups are comparable and the results can be confidently accepted. IOP outcomes were measured at 4 points and compared using the man-Whitney test. Only pre-SLT IOPs differ significantly between the groups. Despite this baseline difference, both groups experienced similar decrease in trend after SLT. This indicates that prior prostaglandin analog use does not affect the final IOP outcome or the rate of IOP reduction. For the assessment of comorbidities, hypertension and tobacco were significantly influence the IOP at 30 days, both negatively affecting the SLT outcomes, with p-values statistically significant. To conclude, topical prostaglandin analogs do not influence the IOP lowering effectiveness of SLT, indicating that these medications do not need to be discontinued prior to laser treatment. Hypertension and tobacco use were identified as factors associated with poorer SLT outcomes. Thank you. Sir, firstly, the previous ALT disrupts the trabecular meshwork and therefore alters the effect of SLT, and that naturally excluded the categorization. As for the secondary glaucoma, glaucomas. This is the first study, prospective cohort, which was conducted in our region, South Asia. And internationally, only one research has been done prospectively. All the researches are retrospective. So we have to actually standardize the whole thing to exclusively find a particular effect of SLT and prostaglandins. That's why we actually categorize everything for primary congenital glaucoma without previous SLT or secondary glaucomas.
Okay. What were the results and how do you justify your study?
So we found that between the two groups, there was, apart from pre-SLT IUP, there was no statistically different end result, which means that regardless of the status of prostaglandin allowed used previously, we do not need to stop them for SLT to have an effect or use them for synergistically enhanced effect for SLT for lowering of IUP. So I guess there was discrepancy in our basically literature that people were saying SLTs have a synergistic effect with prostaglandin analogs, while if some were saying prostaglandin analogs should be, because of their pro-inflammatory effect, should be discontinued prior to SLT. So we have to put an end to that because it's a bit difficult to stop the prostaglandin analogs in a patient who is already on the borderline of raised IUP. So to put that question to rest, we conducted this research.
Vishal Rasool for the talk on efficacy of diode laser in the management of glaucoma following intravitreal silicone oil injection and complicated retinal
Assalamualaikum. I'm Dr. Vishal Rasool, and the title of my presentation today is Efficacy of diode laser in the management of glaucoma following intravitreal silicone oil injection and complicated retinal detachment. I have no relevant disclosures. As you know, intravitreal silicone oil injection is used in complicated retinal detachment. Secondary glaucoma due to silicone oil occurs in 5.9 to 48% of the cases. The raised IOP is often resistant to medical therapy, so removal of silicone oil is the choice of treatment in these patients. Diode laser transscleral cyclophotocoagulation has been used to manage the refractory cases. Removal of silicone oil carries risks like redetachment and monopony. Many patients fail the medical treatment for raised intraocular pressure. Transscleral cyclophotocoagulation offers a minimally invasive, cost-effective alternative. Limited local data is available on efficacy of transscleral cyclophotocoagulation. This study evaluates the role of transscleral cyclophotocoagulation in reducing the intraocular pressure after silicone oil injection in complicated retinal detachment cases. The objective is to evaluate the efficacy of the diode laser transscleral cyclophotocoagulation in reducing the intraocular pressure in patients with secondary glaucoma following intravitreal silicone oil injection for complicated retinal detachment. This is a retrospective observational study conducted at ISTA Postgraduate Institute of Ophthalmology, Karachi, from January 2019 to February 2020 on 58 eyes of 58 patients. The patients from 17 to 81 years of age with raised intraocular pressure greater than or equal to 30 millimeters of mercury post-silicone oil injection were included, and those with corneal decomposition, cataract, uveitis, and prior transscleral cyclophotocoagulation were excluded. The data was analyzed using SPSS version 25. The quantitative variables were analyzed using mean and standard deviation, and the qualitative were analyzed using frequency and percentage. Paired t-test was used to compare the pre and post-treatment intraocular pressure, and chi-square test was used to see the association of efficacy with age, gender, diagnosis, side of the eye, and pre-operative intraocular pressure. P-value less than 0.05 was considered significant. The procedure was performed under local anesthesia, and the laser power used was 1500 to 2200 milliwatt for 2 seconds, and maximum 16 shots were applied on 180 degrees, the two quadrants. The probe UV used was G-probe, and the serial body was visualized using the light illumination 1.5 mm behind the limbus. We spared 3 and 9 o'clock. Same post-procedure treatment was given to all the patients, and same surgeon performed all the procedures. The independent variables are age, gender, pre-treatment intraocular pressure, and vitreoretinal diagnosis, while the dependent variables are intraocular pressure reduction after transscleral cyclophotocoagulation and efficacy that was considered IOP less than 20 millimeters of mercury without further medication at 6 months. Here are the results. The mean pre-treatment intraocular pressure was 37.22 with a standard deviation of 9.15. The overall reduction we had was up to 19.26 millimeters of mercury with p-value less than 0.0001. Here's a graph that shows the reduction of mean intraocular pressure over the time at 1 week, 1 month, 3 months, and 6 months. Here we can see that at 3 months the IOP was lowest, but even at 6 months it was below the baseline. This is a pie chart that shows the efficacy of the transscleral cyclophotocoagulation in silicone oil-induced glaucoma. Here we can see the success in more than 3/4 of the population, that is 77.6%. This is a bar graph that shows the association with the independent variables. Here we can see age, gender, and pre-treatment intraocular pressure had significant association, having p-value less than 0.05, and the rest were not significant. To conclude, I would say diode laser transscleral cyclophotocoagulation is effective and safe for managing silicone oil-induced glaucoma. It reduces intraocular pressure significantly over 6 months. It is simple, cost-effective, and suitable for low-resource settings, especially useful where medical surgical treatments fail. Here are my references. Thank you.
So Royal said applied diode laser in all cases, or you didn't remove?
No, we didn't remove the silicone oil. The eyes that gained silicone oil for 6 months at least were included in the study.
Okay, why didn't you remove silicone oil? Because they were.
Because of the chances of the redetachment in hypotony, the complications.
But every patient with silicone oil will have blindness. So you have to remove oil unless you.
The candidates that were prone to the complications were selected to retain the silicone oil, while those that were quite candidates that could be silicone oil could be removed, they were not included in this study. Only those patients that needed the silicone oil because of these such complications, or were complicated cases like having redetachment, having second surgery for the second time, such cases were included in this
So
study.
all cases which were either operated first time or second time, both were.
Yeah.
Okay, and you didn't note the visual acuity.
No, it didn't include the visual acuity because all the patients usually had advanced glaucoma and uncontrolled intraocular pressures, and the visual prognosis was not very good.
I think visual acuity should be the most important thing which should be also measured along with it.
It was actually included in the performer, but we didn't include it in the results.
Okay. Okay. Any question? Okay. Thank you very much.
Department, Gujranwala Medical College, and I will talk about health-related quality of life assessment in strabismus patients. Before starting my talk, I would like to tell briefly about the motivation behind conducting this study.
Your topic.
This was my topic.
Somehow, Faruqi. Here the topic is power.
So that's due to some matters. So a 32-year-old male was referred from psychiatry department due to deviation of eyeball. The patient had preferred staying at home and no clear trigger was identified. So we examined the patient and we noted that there was a guards and anisotropia, and the patient was having a lot of difficulty in maintaining eye contact. I would also like to disclose that the clinical photos are used after the due consent of the patient. So we booked the patient for skin surgery, and alhamdulillah we were able to achieve a great cosmetic outcome. But in reality, we were able to achieve much more. We were able to give the patient back a smile, and later on the psychiatric remarks that this surgery did more for him than any antidepressant. So this was the motivation behind conducting this study. Effects of strabismus on personal health can be categorized as ocular, cosmetic, and psychological. However, the main effect strabismus has on a personality's build-up is psychological one. Such psychosocial issues include depression, social embarrassment, lack of confidence, poor performance in professional life, marriage problems, and the list goes on. This study was designed to note the psychological aspect of strabismus on the quality of life of these patients. And furthermore, if strabismus is one of the causes of depression, this study also aims to decrease the pool of depression. This was a cross-sectional study conducted at the Department of Ophthalmology, Gujranwala Medical College. We enrolled 35 patients through consecutive sampling technique. Adult Strabismus 20 was used as a tool to find out the quality of life, and this is a validated tool which was introduced in 2009 at the Mayo Clinic, America, and it has been used in dozens of surgeries so far to assess the health-related quality of life of strabismus patients. So the scores can range from 0 to 100, 0 being the worst and 100 being the best health-related quality score. This was the questionnaire we used. First 10 questions are for the psychosocial substrate, while the last 10 questions are for functional substrate. If we look at the demographics of the results, total 35 patients were enrolled, 14 were male, 21 were female, and 20 patients had congenital strabismus, while 15 patients had acquired strabismus. Overall, mean AS20 score was 57.07. Mean AS20 score for males was 60.80, which was slightly greater than females with 52.73 score. Median AS20 score for a normal individual without strabismus is 95 with a range of 85 to 100. Mean AS20 score of adult patients with strabismus in our study was 57.06, which is more than 30 points less than normal individuals. This reflects the level of mental stress and poor psychological impact of strabismus on a person's quality of life. Overall mean AS20 score of strabismus patients was 57.06, which was considerably less as compared to AS20 score for a normal individual, which should have a score of 95. We recommend that ophthalmologists consider the psychological impact of strabismus on a person's life while managing them. Thank you. So this is also one of the limitations of this study, that we included only the patients with more than 18 years of age.
So what impact surgery put on the psychosocial health? What effect this surgery that was carried out affected their?
So we plan to conduct a study to also include AS20 score post-op. So we can compare pre and post-op scores as well.
So post-op what?
Wasn't included.
How can you consider use here visually?
So it has been used in so many cities.
No, it was that the information of the use discussed.
Right.
Okay, very good presentation. Now we move on to our next speaker, Rida Fatima Aslam, for a talk on refractive surgeries, LASIK versus SMILE.
It's a comparative literature review for modern myopia correction. So this is basically what we use for refractive error correction. Myopia is a global health issue affecting millions, and we are comparing two modalities of correcting refractive errors, LASIK and SMILE. So in the literature review that we conducted, we compared these two using the databases that were searched were PubMed, Google Scholar, and we searched the term LASIK versus SMILE refractive surgery outcomes, dry eyes, and also the corneal biomechanics and comparison of the two surgeries. And we included all those studies which were published between 2020 and present. So this is just a procedure at a glance. LASIK obviously uses a two-step procedure. We use a femtosecond ray or microkeratome to create a corneal flap, where in SMILE there is no flap, or there is just a lenticule that is created within the cornea. And the flap can be repositioned in LASIK, and in SMILE this lenticule is removed, and which changes the corneal shape. This is a general glance of both the procedures. And in LASIK, there is a lifting of the corneal flap, where in SMILE is only a 2 to 4 mm small incision. So in the first analysis, we are comparing the predictability and severity. In overall outcomes, LASIK is more predictable as compared to SMILE, and 95% patients achieved 20/20 or better vision in both of them. And we also compared the outcomes at 3, 6, and 12 months of the study. And in the second comparative analysis, we observed that LASIK has flap-related issues, and which is rare with femtosecond lasers. However, there is no flap-related issue with SMILE. There is only a difficult lenticular extraction. If so, incidence has decreased significantly with certain experience. And SMILE, it also eliminates all the flap-related risks. These are some of the risks that are related to the flap. Flap reposition, flap will be have to reposition if there are stria over it also. And this is an example of how the flap can be dislocated. And then we compared the post-op dry eye disease, and this is a common side effect of laser vision. In this, obviously, the smile was the better one because the creation of a large flap will sever a significant number of corneal nerves, and which leads to reduced corneal sensation and dry eyes is a major factor, is a major side effect of LASIK, and this can be prevented using smile. In the fourth comparative analysis, we compared the corneal biomechanics, and in LASIK, this creation of a flap will permanently weaken the anterior cornea, whereas in smile, we don't even manipulate the anterior lamella of the cornea, is completely preserved, and the integrity of anterior corneal stroma is maintained. So in conclusion, both are safe, effective, and predictable procedures for the correction of myopia. However, smile has the advantage of preserving corneal biomechanical integrity and reducing the dry eye symptoms, and absence of flap is a major plus point for smile. LASIK remains an outstanding procedure. Smile is the next evolution in corneal refractive surgery. It offers a less invasive approach with key benefits. However, the enhancements are technically challenging in smile. These are the references. This is a new modification of the smile. With older procedures of smile, there was no correction for high order aberrations, which is now improved in comparison. But wave front guided LASIK can do the same thing. So,
And why the vision is a bit compromised in smile as compared to that? What causes that?
because we are invading the interior of the cornea, so because not much has been done, not much research has been done regarding this. It's the only thing that is not in favor of smile at the moment is that we are not able to enhance if we have overcorrected the patient or undercorrected. So,
Okay, now the world is moving from LASIK to smile through. And what do you think would be the reason for that?
because of all these patients having dry eye symptoms, flap-related complications, and we can manage our regimes according to the patient. We can tailor them, but we cannot say definitely that smile is the best so far because both of them are comparative at the moment. But it is the future technique. People will prefer smile in the future because the flap-related complications and flap dislocation patients who are active in sports probably will not be preferring these things. Physically active patients, flap loss and all that.
Fundamental as glaucoma or cataracts, but it is still one that I find very interesting. I want to talk to you guys today about acknowledging Charles Bonnet syndrome. So, Charles Bonnet syndrome, this thing does not work, so I'll change it from here. Okay, so Charles Bonnet syndrome is defined by hallucinations in individuals with significant vision loss despite having a preserved mental cognition. This was first described all the way back in 1760 at a time when physicians were called naturalists, and this Swiss naturalist, he saw that his grandfather, who was both blind and mentally sound, kept on reporting that he sees buildings and birds and landscapes and people, and they both knew that those things were not there. So, this has been continuously reported in worldwide literature that in patients with severe vision loss, 12 to 26% of the patients will have visual symptoms. However, it is criminally underreported in Pakistan. If you were to plug in the words Charles Bonnet syndrome Pakistan into any major search engine, you would get 0 hits. So we set out with the objectives to record the frequency of Charles Bonnet syndrome in visually impaired patients, and we also wanted to assess the severity and quality of these hallucinations, and we also wanted to see if the patients faced any distress because of this, and if finding out about the disease helped them. So the methodology was that it's an ongoing cross-sectional study, and it's a mixed method study. Basically, it was a descriptive study, but because we were having qualitative interviews with each of the patients, it became a mixed method study. So far we have 97 consecutive patients who satisfy the inclusion criteria of being more than 50 years, and since we need a preserved mental cognition, the mini mental state examination score of more than 24 was required. We used a structured questionnaire, which was pre-validated, and we looked at different researches done on Charles Bonnet syndrome, and we made our own because the questions in that was specialized to the specific population. Since our population is mostly uneducated and they have to be told in layman terms, we made our own version of the questionnaire. And through this questionnaire, we assessed the hallucination presence, duration, frequency, what the distress phase was, what the impact on activities is, and if there were any coping strategies. So, after satisfying the inclusion criteria, we included patients who saw visual hallucinations in the absence of psychiatric neurodegenerative disease, and a qualitative interview session was done with each patient. What did we find? We found that Charles Bonnet syndrome was identified in a staggering 23 of 97 patients. That's about a quarter of patients with severe vision loss suffering from visual hallucinations. The mean age was 68.4 years. The most common cases who faced these visual hallucinations included cataracts, age-related macular degenerations, and diabetic retinopathy. We even had a few isolated cases of glaucoma, retinitis pigmentosa, and traumatic vision loss. Now, the next thing which happened was really interesting. When I would ask these patients, "Kya aap logo ko kuch nazar aata hai? Do you have any hallucinations?" There would be no, we don't have any hallucinations. But when I would explain to them that this is a disease, it's in literature, ye hamari kitabon mein hai, almost 1/4 of the patients have it, slowly they would say, "Doctor Sahab, haan, mujhe kabhi kabar nazar aata hai." Now, the next thing blew me away. When I would ask them, कि दिन में कितनी बार नजर आता है या हफ्ते में कितनी बार नजर आता है, तो almost half of them said we see the hallucinations every day. They were reluctant to tell me about the hallucinations because of the taboo mental health is. No one wants to be labeled a psychiatric patient. And then the next part was even more interesting. When I asked them कि आप लोगों को क्या नजर आता है, they said landscapes, buildings, they saw their relatives, someone mentioned Benazir Bhutto. Basically, these were things which I could never have imagined, that they're seeing such complex and such vivid hallucinations. And I can't really show you what my patient saw, but here is a rendition of a professional artist who drew what these patients see. And you can see that the hallucinations are quite complex. So the next thing we wanted to see was that if the patients face distress, almost 8 patients faced high distress and the other patient faced some modicum of distress. And the way they coped with this was by increasing lighting, using counseling or distraction techniques. Now, the next thing was that some of the patients said that the distress is enough to affect their day-to-day life. And all of these patients also claimed that their symptoms improved after finding out about the disease. And that is what is unique. And what I liked about the study is you could help the patients just by telling them about the disease. And that is why my presentation is called Acknowledging Charles Bonnet Syndrome. In conclusion, 1/4 of visually impaired patients experience CBS, and I feel routine screening and counseling could really improve the quality of life. Thank you so much.
Very nice presentation. Questions from the audience? I have a question. You included 7 patients of cataract.
Yes.
So, considering they were probably hand movement or anything less, so would you consider having the cataract removed and then assessing it as well, or what?
Yes, so that could be another study which could be done. Do these visual hallucinations improve after the vision gets back? But since I have not yet completed this study, our sample size was proposed to be 167, and so far we have only collected 97 patients. So that could be down the line. One thing is that our patients are really difficult to follow up. But if I get an opportunity, I definitely want to do something on this, that if you could improve the vision in these patients, do the hallucinations get better? The biological plausibility is that it will get better. But so far, I have not studied that aspect.
If I be allowed another question.
Yes, yes.
So basically, there's a thing called victimization bias. So if you consider having an interview with the patient and then he has a recall bias, like patient do not forget, or then you just basically encourage them or you educate them about the possibility of symptoms. So there's a majority of patients who would prefer being like it gives them a bit of like relaxation of being a victim of a disease rather than this. So did you consider this aspect as well, which could be confounding the results?
So the way in which this study was made, are a lot of biases. But considering that there is no work done on Charles Bonnet, I thought it is better to start somewhere. We can have a study with some errors and get a modicum of idea if this disease is even present in our population. Once we have that, from there we can refine a better study with try to improve the biases. So far, you're right. There are biases. There are technical faults in how the study was structured. But I feel it is a good place to start researching this topic. Thank you so much.
Now we move on to our next speaker, Usman Tariq. Is he here? Daniel Khan, will you be doing the second of your
Yes.
family struggle with people in
Sir, I think I got an email. They said you can only do one presentation. Thank you.
Sharif Shabir Khan? Is he here? Zainab Naeem Khan? Shafaq Tanveer? No. So with this, we conclude this session.
A good presentation on those various topics, glaucoma, secondary treatment. The other was on effect of squint on teeth. So it is happening to see you here, but at the same time, it's very disturbing that the session which was prepared for the residents, most of the residents they are absent. So this once they have concluded or they have included themselves into this, they must be prepared. Last time, few were missing. So Professor Daud, he was here, he was on the first bench, and he remarked that there should be a bar on them, that they should not be able to present next time. So we are not following that, but to that extent, if the interest is of the residents is this, that they come for they send their presentation, but they don't come for presenting it. So we will be considering that. So Professor Daud already actually is very much against this.
So as we all know, ND-YAG laser is an optically formed laser which emits infrared light at 1064 nanometers, which when fused with can be produced at 532 nanometers, and it acts by photodisruption. Its indications include capsulotomy, anterior capsular phimosis, malignant glaucoma, iridectomy, and vitreous vein. What we did YAG laser vitreolysis for symptomatic floaters. Our objective was to determine the outcome of ND-YAG laser vitreolysis among patients with symptomatic floaters. A bit about floaters. Vitreous floaters result from posterior vitreous detachment from optic disc, tugging along ganglion cell complex, which is clinically perceived as vitreous opacity. Our operational definition included symptomatic floaters, which is clinically visible floaters for 3 months. ND-YAG laser vitreolysis is photodisruptions through Vogue mid-vitreous Idris lens. A Vogue mid-vitreous Idris lens was used to easily identify the floaters with greater stability, and it is a high-resolution direct contact lens. Our study was a descriptive study, and sample size was 113 at a confidence interval of 95, calculated through OpenAPI. Our inclusion criteria was patients above 20 years with symptomatic floaters. In exclusion criteria, ocular pathology including RD, glaucoma, uveitis, and other ocular pathology, including significant cataract, which can obscure the view or cause scatter of the laser. And we also excluded patient of myopia greater than 6. Complete ocular examination was performed, emphasizing on peripheral plates. All patients were followed for 4 and 8 weeks. This was the performer that we did. And the outcome was assessed on complete, partial, or no improvement at 4 and 8 weeks. Both subjective and objective parameters were taken. Data was analyzed with SPSS 22, and after stratification, p-value of less than 0.05 was taken as significant. Our mean age of our patients was 55, with 35% being pseudophakic and rest aphakic. Not all of our patients had complete improvement, but overall improvement compared to no significant had a p-value of 0.01, which was significant and proved our hypothesis to be correct. After stratification, having better outcomes with patients having no comorbs was significant with a p-value of 0.03. There was no difference between the pseudophakic or phakic patient according to the p-values. One of our patients developed retinal detachment. He underwent immediate pars plana vitrectomy with gas tamponade. His visual acuity after 3 months of vitrectomy was 6.9. So coming to the discussion, ND-egg electrolysis can offer a significant improvement in symptoms for a substantial proportion of patients. Historically, the only treatment offered for symptomatic vitreous floaters has been pars plana vitrectomy. Using new mid-vitreous contact lenses provide surgeon with full visualization of the entire vitreous cavity from the lens to the retina with greater stability. This was our research that was published. Thank you. Vitreous detachment more than 3 months. More than
PVD cases.
Or PVD cases. The ones which there was a reason, a significant reason.
So, how many shots were?
Sir, depending on the type, in some cases only 2 to 3 shots just photo disrupted the. But in some cases the shots went to 20 to 25 shots.
Settings.
Settings again depending on the thickness of the leaf vein. In some cases it was the average was around from 2.1 to 4.4.
Okay, there was no other pathology, only this white ring was disrupted.
Yes, in the research we included this, but other than that we also did for some after the BC ring there were some small nuclear fragments also in the vitreous.
So that was included in
No,
this study?
in this research it was not included. Other than that, we did.
Thank you.
Any complication?
Just one complication that we noticed that I mentioned, we missed taking the history of the patient. He had a strong family history of retinal detachment. Otherwise, there was no break in the pre-op, and we performed these scan in every cases, but he had a strong family history, so that's why maybe he developed retinal detachment.
Okay. Thank you.
Thank you.
R4 resident from POPR Hospital. Today I am going to present a case of a 54-year-old male with no known comorbs presented with a complaint of drooping of right upper lid, which was present since childhood and aggravated after trauma. His best rated visual acuity was 612 in the right eye, whereas 6.9 in the left eye. On examination, right eye had severe ptosis, the rest of the anterior and posterior segment examination was normal. On further examination, pupil pressure height was 2 mm in the right eye, whereas 9 mm in the left eye. This picture depicts 9 diagnostic positions, and as we move along, the right eye had severe ptosis, and there is going to be limitation of textual elevation, and levo elevation. Rest of the extraocular movements were normal. On orthoptic assessment, right eye had severe ptosis which was present in the primary gaze. On cover and cover, there was hypertrophy of the right eye. Hunchback was 15-degree hypertropia and present cover test was 25 present diopter base up. Is the patient having true ptosis? So in order to find out that whether the patient is having pseudoptosis, we covered his left eye and there is marked improvement in his ptosis. As there was history of trauma, so we went for CT scan which came out to be normal. Based on the above findings and my examination, my differentials were monocular elevation deficiency, blood fracture, Brown syndrome, and congenital fibrosis of the extraocular muscles. So now I'm going to rule out one by one. As there was CT scan was normal and there was history of trauma, so there was no blood fracture. And there's going to be limitation of elevation in adduction in Brown syndrome. And when we talk about the CFEOM, that is the congenital fibrosis of the extraocular muscle, there's going to be bilateral ptosis, universal, and there's going to be bilateral hypertropia. Management was based on, so these were the objectives of my management: to alleviate sedative ocular motor imbalance, to correct pseudotosis, and second one, to conduct ptosis surgery to correct any residual true ptosis component. And so for that, I have two options. Either we can proceed for NAP procedure or inferior rectus recession. Which procedure I have to opt for is based on the force reduction test. If the force reduction test is going to be positive, we will proceed for inferior rectus. If it is negative, then NAP procedure. This force reduction test demonstrates So I am explaining it verbally. This force section test demonstrates that the eye is not going up and is not crossing the midline, but the eye is moving freely in down gaze and in rest of the gazes. Since FDT was positive, inferior rectus lesion of 6 mm was planned. This is the surgical demonstration of the procedure that we have performed. So we are able to achieve our main objective. After the procedure, we can easily appreciate that the eye is in the primary position, ptosis has also been improved, and our main goal is achieved, which is to bring the eye in the primary position. In conclusion, I would like to say the choice of a reasonable surgical method not only correct primary deviation but can also improve ocular motility. The etiology being complicated, if proper surgical procedure is selected, most cases with monocular elevation deficiency can achieve good therapeutic outcomes. Thank you.
Question from the audience.
This is based on one case or you have a case?
This is my case presentation that we have placed in our hospital.
Okay, what is NAP procedure?
So in that procedure, what we do is basically we resect the interior half radius of both the recti muscles, and then we transpose it to the superior rectus.
Okay. This is the primary first stage procedure. And the second stage procedure?
So then we have option of augmented NAP and modified Nishida if there's going to be further restriction.
Okay, thank you very much.
Thank you.
Now we move on to our first speaker, Amsa Tahir, for a talk on assessing vision-related quality of life in patients with diabetic retinopathy.
I'm Dr. Asma Tahir, resident ophthalmologist, and my paper that I'm going to present today is about assessing vision-related quality of life in patients with diabetic retinopathy. Diabetic retinopathy, as we all know, is one of the leading causes of visual loss, occurs due to prolonged hyperglycemia and ultimately directly affects the quality of life of patients. The objective of my study was to evaluate the vision-related quality of life in patients with diabetic retinopathy. It was a descriptive cross-sectional study conducted from 10 June 2024 to 10 December 2024 for 6 months duration. Sample size was calculated to be 70 using WHO sample size calculator where the confidence interval was kept at 95% with a margin of error of 5%. The patients aging above 18 years, both male and female, having type 1 and type 2 diabetes, and diagnosed cases of diabetic retinopathy according to the ETDRS classification were included, whereas the patients who had any neurological disorders, psychological disorders, history of ocular issues like age-related macular degeneration, glaucoma, non-diabetics, and patients who underwent intraocular surgery within 6 months were excluded from the study. The overall result came out to be the quality of life score was mean 34.328 with a plus-minus standard deviation of 19.37. Age-wise, the mean age of the patients was calculated to be 58.9, with 36 males and 34 females, 51.4% males, 48.6% females. The duration of diabetes was 19.6 years. Type 1 was 15.7% and type 2 84.3%. The mean quality of life score in comparison to age, with respect to age less than 45 years, was 39.4, which was more as compared to people of the older age group of greater than 45 years, for whom it was 32.92%. The mean quality of life score, gender-wise, for males it was 33.58, whereas for females it was 35.11. Quality of life score with respect to the duration of diabetes for patients who had diabetes less than 20 years was 37.2, whereas it was significantly less for patients having duration of diabetes of greater than 20 years, for whom it was 31. So coming towards the discussion, longer the duration, the greater its impact is going to be on the quality of life of patients. Patients with proliferative diabetic retinopathy had low scores on quality of life. Weiser T. et al. In his study also used NEI-VFQ, that is the National Eye Institute Visual Function Questionnaire 25, and he stratified the patients in 2 groups. The stratas were not used in my study, but his patients in the group of proliferative diabetic retinopathy had a similar quality of life score of 35.3, which lies in close approximation to my study results. Similarly, Amadi and et al. Reported a worse quality of life for diabetic retinopathy patients with a mean score of 33.4, which aligns closely with my finding of 34.3. So our study was consistent with the previous studies. These are the references of the previous studies. The limitation of my study was that it had a smaller sample size and lots of patients to follow up. For future directions, I would like to suggest a more extensive multi-center study with longer follow-up duration and larger sample size should be taken into account. In conclusion, I would like to say that diabetic retinopathy affects vision-related quality of life. Early screening is the keystone to improving quality of life, and lifestyle modification still remain cornerstone. So, sweets or vision, the choice is ours. These are the references that I used. Thank you.
Question from the audience.
Do you have a performer how we calculate it?
Sir, I have a performer. It's available on the National Eye Institute, and it's there modified already. Like it's with them, and it's available on the website. And I use the same questionnaire.
So how many questions were there?
Sir, it was divided into 6 segments. The first one were about general health. The second one were about daily activities like driving, reading, and in the third it was about doing normal functions like can they walk, how easily can they identify objects, and in the last one it was about household chores that they can do. It was divided into 6 segments. It's available on National Eye Institute website.
We used modified question.
Yes, sir. There are different available. But the latest one, that is the 2021 edition, that consisting of 25 questions. So I used NEIVFQ 25.
And you made this validity.
Sir, I did not modify it. It's already modified by them.
The permission from the author?
No, sir, it's already modified. They have named it as modified to their website. The National Eye Institute, it's available on their website as modified. The modifications were not done by me.
Okay, but we have to take permission from the author.
Sir, on the website, it's mentioned that the permissions are given once we, like, it's open access to them.
And today my talk is on outcomes of early detective and diabetes damage with high proliferative diabetic retinopathy. Proliferative diabetic retinopathy is a serious complication of diabetes that leads to blindness. High blood sugar level for longer duration leads to damage the small vessels of retina. Blank vitreous hemorrhage occurs when retinal blood vessels bleed into the vitreous cavity. Beam skin ultrasonography was performed to confirm the presence of vitreous hemorrhage and to exclude other causes like vitreoretinal fractional bands or fractional retinal detachment. The purpose of our study is to identify outcomes of early vitrectomy and dense vitreous hemorrhage due to PDR. This was cross-sectional study conducted at Institute of Ophthalmology, Liaquat University of Medical and Health Sciences, Jamshedpur for 1 year duration, from 1st April 2023 to 31st March 2024. The sample size was 36 and it was calculated on OPDPL sample size calculator. In inclusion criteria, all patients of both gender from age 40 to 80 years who presented in our OPD with complaint of vitreous hemorrhage secondary to PDR were included in the study. However, all other causes of vitreous hemorrhage, like any other corneal pathology and fractional retinal detachment or VRT, were excluded from the study. 23 gauge parts per vitrectomy followed by air fluid exchange with endolaser was performed. However, we also used silicone oil in some patients as an internet tamponade. In our study, 22.2% patients were of grade 3 vitreous hemorrhage and 77.8% were of grade 4 vitreous hemorrhage. Out of them, females were 44.4% and males were 55.6%. This is the fundus photograph of the patient with dense vitreous hemorrhage. The pre-operative best rapid visual acuity was hand movement, and you can see the presence of hemorrhage on B scale also. This is the post-operative fundus photograph of the same patient. After 8 weeks, visual acuity was improved to 6/36, and you can see there are signs of diabetic retinopathy with clinically significant macular edema. This is another patient with dense vitreous hemorrhage. Pre-operative visual acuity was hand movement, and after vitrectomy, best corrected visual acuity was improved to 6/18. There are also signs of diabetic retinopathy, and laser marks are also visible. In our study, after 8 weeks, visual acuity was improved to 11.11%. The visual acuity was 6/60. In 38.88%, it was improved to 6/24. In 30.55%, it was improved to 6/12. And in 19.44%, it was improved to 6/9. So this study shows that there is significant improvement in best corrected visual acuity in patients with operated early vitrectomy and dense vitreous hemorrhage. However, in 2 patients, recurrent vitreous hemorrhage was also observed after surgery. As JCJ et al., Fernando J et al., Obata S, and Renos P et al. Have reported there is significant improvement in best corrected visual acuity was observed in patients with vitreous hemorrhage without retinal detachment. These are my references. Thank you.
Any question from the audience? Okay, what are the special precautions which you take before embarking upon pars plana vitrectomy?
So we will include those patients who have dense vitreous hemorrhage and we checked the random blood sugar level who have controlled diabetes at that time, and sir, no any other precautions.
Did you give any injection, anti-VEGF before going for the vaccine?
Sir, we have included only those patients who have dense vitreous hemorrhage, so we did not give an anti-VEGF at that time.
So dense vitreous hemorrhage of how many months old did you go for?
Sir, we have used only those patients who have dense vitreous hemorrhage and early vitreous hemorrhage. They have diagnosed at that time, and as soon as possible we have performed the surgery.
So, do you think that if you will give anti-VEGF before surgery, will it make any difference or not?
Sir, in these cases it might be not, because they have already dense hemorrhage. In small hemorrhages we can give anti-VEGF.
What we actually do before going for pars plana vitrectomy is that we
have options of anti-VEGF.
Operate within a week's time so that it doesn't bleed. Otherwise, sometimes it bleeds and you have to go for silicone oil. So, and also it's useful to give anti-VEGF because the blood vessels actually close. Otherwise, sometimes it becomes very difficult to surgery. Any questions? Further questions? Okay, thank you. So we go with the next speaker, Zishan Hamid. Is he there? Mirza Altamash M. Beg for his talk on the psychological impact of visual impairment amongst patients presenting at a tertiary hospital. A cross-sectional study from Karachi.
Tackling the psychosocial impact of visual impairment with my supervisor, Dr. Musa, and do not have any disclosures listed. So here we have some statistics of the global and local impact of blindness and visual impairment. But what is the impact? As ophthalmologists and as doctors, we realize that sight is one of the cardinal senses of any living being, and it is simple enough to imagine the impact by just closing our eyes for 30 seconds the next time we're seated in the passenger seat of a car, or when we're going up or down the stairs. And those 30 seconds are simple enough for us to realize how the blindness or severe visual impairment impacts an individual. So here is a non-exhaustive list of some of the impacts, and to quantify this impact is the purpose of my research. I went forward with this research because there's a gap in literature from Karachi, which is Pakistan's most popular city with a diverse cultural and social background. And the importance is that it can help guide coping strategies for these severely visually impaired individuals. So my objective is to assess and compare the vision-related quality of life and the social support available to these individuals who present in our clinic. So the vision-related quality of life will be assessed using the impact of vision impairment questionnaire developed by SERA. This is a 28-item questionnaire consisting of the emotional and functional domains of quality of life, and scored on a 4-point rated scale. This will be followed by assessing the social support available to these individuals using the MOS tool, which is a 19-item tool rated on a 5-point rated scale, assessing the emotional, tangible, and affectionate support available to these individuals. The eye diseases included in my study are limited to diabetic retinopathy, glaucoma, and refractive errors. This is a cross-sectional study being conducted at the Department of Ophthalmology and Visual Sciences, Khan Hospital, Karachi, and is currently underway with data collection for a total duration of 6 months since the ERC and CPSP approvals have been given. So we're recruiting 18 to 70-year-olds of either gender with presenting visual acuity of 20/40 or worse with the eye diseases that I have previously mentioned, and who are able to understand English and or Urdu. And we have some general screening criteria. So the sample size we're looking for is 295 with a margin of error of 0.8 using a non-probability consecutive sampling. The data collection procedure is currently underway, and to negate any preferential bias, we are not collecting any personal identifiers, and to minimize potential reporting bias, our data collectors are being thoroughly trained and supervised to reduce any systematic errors. The data is being kept completely confidential. Here is a brief data analysis that will follow the eventual data collection procedure. The correlation between the IVI and the MOS scores will be conducted using the Spearman correlation with a p-value of 0.05 considered or less considered as statistically significant. So my expected outcomes here are that people with greater degree of visual impairment will have worse functional and emotional well-being scores and will require more emotional, tangible, and affectionate support in their lives from their friends, their family, their relatives. The benefits will be for the patients, the clinicians, as well as the policy makers. These are my references, and I acknowledge these people for their help. And I'm open to questions.
Any questions from the audience? So you divided it into three groups by the refractive errors, glaucoma, and cataract. So what are the different psychological effects, impact of visual impairment, and what do you rate the most difficult ones?
For the literature search for this research, I went through the 2030 vision guidelines, the Geneva vision guidelines of WHO. And currently, the thing that they are targeting is refractive errors, which is one of the most underdiagnosed and easily correctable state, but it is not being corrected throughout the world. And so, even in Pakistan, as the statistics that I showed, refractive errors are the leading cause of visual impairment, not diabetic retinopathy only.
Any other questions? Okay, thank you very much.
Thank you so much.
Now we move on to our next speaker, Mia Hassan Ali, for his talk on refractive outcomes of retinopathy of prematurity after laser photocoagulation or intravitreal anti-vascular endothelial growth factor.
Presenting on refractive outcomes in retinopathy of prematurity after laser photocoagulation and intravitreal anti-vascular therapy. First of all, introduction. What is retinopathy of prematurity? It is a disorder of abnormal retinal vascular development in premature infants caused by oxygen fluctuation, vegetative imbalance, and abnormal neovascularization. We can lead to traction, retinal detachment, and visual impairments. Pathophysiologically, in overview, there is premature birth, decreased oxygen exposure, decreased anti-vascular growth factor, and lead to ischemia and vascular arrest. Hypoxia, increased VEGF levels, and it will lead to abnormal neovascularization. Treatment options, we have laser photocoagulation, anti-VEGF therapy, and combination therapy. So previous literature and studies, internationally some studies have been done on this, and which shows that patient treated with intravitreal anti-VEGF has less myopia than those treated with laser photocoagulation. While few studies shows no influence of laser or anti-VEGF on refractive outcomes. Nationally, only few studies done so far, so there is conflicting evidence on the refractive effects of anti-VEGFs and laser. So the objective is to evaluate the refractive outcomes of children treated for RFP using laser photocoagulation, intravitreal anti-VEGF, and combination treatment. So why are they important? The importance of refractive outcomes is that high myopia can lead to amblyopia and strabismus, and it is essential for long-term visual prognosis.
This my inclusion criteria: children aged 2 years to 8 years, the history of treated ROP in LGH using either laser photocoagulation, intravitreal anti-VEGF therapy, or combination. Type 1 ROP, no history of other ocular conditions that can affect the effective outcomes, especially congenital cataracts, glaucoma is. Studies done after the informed consent by the guardians or parents of the child to participate in this. This is the exclusion criteria. The previous history of any ocular surgeries, vitrectomy and severe buckling, which influence the effective outcomes. Stage 4 and stage 5 ROP. Children with systemic syndromes, Down syndrome, Marfan syndrome, and children with a previously ongoing treatment for embollia and strabismus. Study design, material methods, study conducted in the Hall General Hospital. It is cross-sectional study. Sample size calculated 56, aged 2 years to 8 years, and data collected by cyclophagy refraction, retinoscopy to calculate the reflective color of the patients. And of course, the ethical review from the institutional review. This is the demographic data. Patients, number of participants, total 56, and 26 were male and 30 were female. Total eyes 112. The patients who received anti-VEGFs were 28. And the laser photocoagulation 14 patients, and the combination therapy was also 14 patients. Total eyes who received anti-VEGF were 56, and laser photocoagulation 28, and combination therapy 20. Result summary: after doing the cyclophagy reflection of these patients, mean myopia comes out to be minus 1.75 diopters after anti-VEGF injections, and minus 3.25 diopters after laser photocoagulation, and minus 3 diopters after combination therapy. Mean age of the patients 4.25 years, standard deviation 1.34 years. This is post-hoc analysis. There is significant, you can see p-value significant in case of anti-VEGF versus laser, anti-VEGF versus combination treatment. So I conclude here, anti-VEGF group has significantly lower myopia than laser and combination treatment groups. These are the references. Thank you very much for it.
Any questions from the audience?
What was the inclusion criteria? Like which guidelines did you follow for including the other PPPs? We have different guidelines. Huh? Which one did you use?
I included on type 1 ROP patients.
But like how much week old babies? What was the weight that you included?
Weight less than 2,000 grams.
Less than 2,000. And these were according to which guidelines?
The guidelines in Pakistan. I think recently, yesterday, the guidelines slightly changed. 36 weeks patients are also less than 36 weeks are also now included in the ROPC training. So we included according to the Pakistan guidelines.
Any other question? Okay, thank you, Edwin. Now we move on to our next speaker. Talk on suprachoroidal injection of triamcinolone for the management of resistant DME.
And my topic for today's talk is suprachoroidal triamcinolone for resistant macular edema. So no financial disclosures. As you all know, diabetic macular edema is the most common cause of visual loss in diabetes. Anti-VEGF therapy is the standard, but patients show resistance in it. suprachoroidal route offers the targeted delivery with fewer side effects. So our rationale of our study was to evaluate the clinical effectiveness of the suprachoroidal injection in the resistant diabetic macular edema and determine the anatomical and functional outcomes. The objective of our study was to assess the reduction of the central macular thickness and improvement of the best corrective visual acuity following triamcinolone suprachoroidal in resistant diabetic. So methods were we use a POSI experimental study from May 2023 to April 2024. 60 patients were included in this study and 70 eyes were used. And suprachoroidal triamcinolone 4 milligram dose was used in a single injection, and follow-up was 1 and 3 months. And outcomes were central macular thickness, IOP, and best corrective visual acuity. So our inclusion criteria was all adults with uncontrolled diabetic uncontrolled diabetes with type 1 or type 2. Resistant central macular involving diabetic macular edema, best corrective visual acuity less than 20/60, and inadequate response to 3 or more than 3 intravitreal injections. Exclusion criteria was macular edema for non-diabetic causes, any other causes like after surgery or uveitic inflammatory or any other, and IOP of more than 20 millimeter of mercury, cataract, macular ischemia, uveitis, renal diseases, and intravitreal triamcinolone with previous less than 3 months, within 3 months. Procedure details were we used modified 1 millimeter needle, exposure using insulin syringe. Injection was delivered 3.5 millimeter from the limbus, and steroid deposit with the suprachoroidal space. Post-injection ophthalmoscopy was used to confirm the pregnancy. Statistic analysis were SPSS 20 software was used and repeated measures with ANOVA with one-sided correction, and p-value of less than 0.05 was considered significant. And results were mean age was 49.25 and 54% were male and 46% were female, and significant improvement at 1 month and 3 months in all parameters. So in this graph we can appreciate that at the presentation the central macular thickness is approximately 780 micrometers, and at 1 month follow-up it decreases to 280 micrometers of the central macular thickness. Then 3 months is reduced to 250 micrometers, the central macular thickness. And this we can appreciate that the baseline IOP was approximately 13 millimeters of mercury, and which raised to 13.8 at the first month, and then again dropped to 13.3 at the third month. And best corrected visual acuity was this was based on logMAR, so it was 0.1 means 660, and at the baseline, and at 1 month it improved to 0.3, which was 618 approximately, and at the third month follow-up it also improved further to 0.3, like 616. And discussion as we suprachoroidal triamcinolone produced rapid and significant anatomical improvement. Best corrected visual acuity improved by 9 letters on average, and minimum IOP rise and no complication observed. Consistent with the outcomes of the HULK and the transient HULK was a similar study with reperform and transient use comparison of the intravitreal triamcinolone, intravitreal anti-VEGF and suprachoroidal triamcinolone. So our limitation, there were some limitation of our study, like small sample size, only 60 patients were included, short follow-up duration only 3 months, and no control group. So to conclude, suprachoroidal triamcinolone is a safe and effective alternate for resistant diabetic macular edema, showing strong anatomical and visual improvement with minimum complications. Thank you.
Any questions from the audience?
Yes, sir. आपने बताया कि इसके बहुत अच्छे इफेक्ट्स हैं, तो क्या हमें क्या प्राइमरी ट्रीटमेंट इसको यूज कर सकते हैं, बिकॉज इट इज मच कॉस्ट इफेक्टिव एज कंपेयर्ड टू एंटीबायोटिक्स?
कर सकते हैं, लेकिन जो स्टैंडर्ड जो ट्रीटमेंट तो प्रोटोकॉल का स्टैंडर्ड प्रोटोकॉल को एंटी वेजेस हमें यूज करना है ना। और इसकी कॉम्प्लिकेशंस मीन कि सबसे ज्यादा मेन कॉम्प्लिकेशन पेशेंट पेन के साथ आता है। इंटरवेजेस के साथ इंटरवेटेड वेजेस के साथ एंटी वेजेस में पेशेंट को पेन नहीं होता। इसमें तो पेशेंट तो आप कभी भी अपने क्लिनिक में अपने हॉस्पिटल में आप ट्राई करेंगे तो पेशेंट इस इंजेक्शन से भागता ही है। रीजन ये पेन बहुत होता है इसमें। तो दिस इज द ओनली कॉम्प्लिकेशन जो वी फेस। सो इसलिए
but it is very much cost effective.
yes, exactly, that was very good question.
So, if you burn operatively, the pressure rises.
Yes, sir.
So, what did you do?
So, stress in this area of anterior temperature. So, 0.1 ml हम लोग इंजेक्ट करें तो वही 0.1 ml हम लोग दें anterior temperature को वो press करें. So, pain was reduced and IP was.
Okay.
We checked this. Immediately we check the optic disc also. So, see the pulsation to see. I will be right on the एकदम pulsation see.
So, how do you check it?
So, indirect ophthalmoscope at the trigger. Every case. Dilate करके हम लोग. ये हमारा protocol है.
When you are checking the pressure, you should know that it is okay. हर केस में देखने की जरूरत है.
वो protocol हमारे supervisor ने बनाया है.
ठीक है. And after 3 injections of anti-VEGF, if they are not so much responsive, then you did this.
Yes, after 3 months.
After 3 months, yes. What complications can occur with suprachoroidal?
Suprachoroidal obviously.
And what are the milligram? How many milligrams you can give?
4 milligram and 2 milligram. We use 4 milligram, and the most common complication is raised intraocular pressure, cataract formation, and इंटरविट्रल चले जाते हैं इंजेक्शन। तो अगर से डिस्प्लेसमेंट नहीं हो और एंडोफर्मेटिस जो होता है सुप्राकॉर्डियल हेमरेज हो गया।
Okay, thank you. Any questions?
Is there any difference between 4 milligram and 2 milligram dosage?
वो जो ट्रांजिट स्टडी थी वो बेसिकली इसलिए की थी और लोग ने डिफरेंशिएट किया।
ये आप कितने क्लिनिकल
हम लोग ने 4 मिलीग्राम यूज करते हैं, जो प्रोटोकॉल हमारा हॉस्पिटल है। तो हमारे पर 2 मिलीग्राम से रिस्पॉन्सिव नहीं था, so we use 4 milligram.
Okay, we can talk about it lots and lots, but
Good morning and Assalamualaikum everyone. I'm Dr. Mukhtar Raza, first year resident of ophthalmology at Mr. Hospital Multan. Today I'm honored to be able to present my clinical audit and something very deeply meaningful, that is penetrating keratoplasty audit at Mr. Hospital Multan, focusing on the reasons, patient life challenges and post-graft satisfaction. This audit was carried out by me, my amazing team of colleagues, and supervised by Professor Dr. Rashid Kamarao. Alright, so we all are very well aware that penetrating keratoplasty involves replacing a diseased or a damaged cornea with a healthy donor cornea. This surgery improves corneal clarity, improves vision, and significantly reduces ocular discomfort. Now, this surgery for most of the patients isn't just a mere surgery. Rather, it is a life-changing intervention, improving vision, restoring confidence, independence, and overall quality of life. We at the ophthalmology department of Mr. Hospital have successfully been able to perform 218 penetrating keratoplastic surgeries, catering patients that were deserving and non-affording from all over the South Punjab, improving their vision and rewriting stories of patients who had almost given up. Alright, so this audit focuses on the reasons why patients needed PKP, patient life challenges prior to the surgery, and the post-graft satisfaction they experienced afterwards. The duration spans from March 2022 to December 2024, and we included a total of 110 patients out of the 218 surgeries we have already performed, aging from 5 to 55 years. We use a very structured approach, a detailed history, thorough examination, all the relevant investigations, and a detailed questionnaire focusing on the very human side of the disease. Now, for the reasons, here are all the data we collected. So we can clearly see congenital opacities top the list, followed by scars, dystrophies, bullous keratopathy, and so on. Now, this was the questionnaire we shared among the patients prior to the surgery and then 6 months later. And it clearly focuses on all the important domains of life, including the daily life functioning, ocular discomfort, cosmetic appearance, social and psychological impacts. Alright, so for the patient life challenges, here's the data that I was able to obtain for the individual questions. And here I have categorized it into all the 5 domains I've mentioned earlier for ease. These are the post-graph satisfaction levels. And again, I've categorized it into the 5 domains I've mentioned earlier. Now this, ladies and gentlemen, is what truly matters. The change before and after the graph. Here I've categorized and summarized the entire statistical data that I was able to obtain into one same table, side by side for better comparison and analysis. And I really need your attention here that please have a look at the percentages and figures. 60 to 70% improvement, that is remarkable. Now, the patients who were unable to perform the daily basic tasks are now reading, writing, walking, driving, you name it. They are returning to work confidently and are reclaiming the independence they thought they had lost forever. Now, this table, ladies and gentlemen, isn't just numbers. It is 110 lives transformed. In the end, I'd like to play a video showing just a glimpse of how positively impactful PKP has been for our patients, highlighting the importance of PKP and the need for it to be made available and promoted at all levels. इसका volume please करें.
ये फिर हमें जो ऑपरेशन हुआ है ऑपरेशन ठीक है और स्कूल भी आज क्लास कर लिया और वही का बाद में नजर आने शुरू हो गए बच्चे के दो ऐसी चीजें होती जैसे बड़े होते हैं इनको भी होता है कि पढ़ नहीं सकते रोजमर्रा की जिंदगी में तकलीफ होती थी तो कहीं आने जाने में परेशानी होती थी बच्चे बीच से थे तो परेशानी बढ़ती थी जब से अपडेट हुआ मैं बड़ी खुशी है हमारे बच्चों की नजर ठीक हो गई है हम तो ये कहें जिन लोगों को ये मसला है वो आए इस तरह आगे चेक कराएं
हाँ ऐसा ना लगता है कि मैं तो अब मैं यहाँ काफी बेहतर है पहले मैंने जब मैं बीच में इसके वजह से मैं बिल्कुल आपको सही हो गई है अब भी बेहतर है इस बार हो गया चीजें मैं मुझे देखने में बड़ा विश्वास करती है अब काफी बेहतर है मुझे भी नहीं मालूम है से कुछ बीमारी है काफी बेहतर हो गई अब सही है
Thank you, everyone. Thank you for your time.
Question from the audience. Yes.
Have you published this study? Not yet. We're still in the process. We're trying to increase the sample size more to make it like more effective than only then we'll publish it.
What are the causes of poor results?
Yes, हमारे पास एक और study है that is still undergoing और उसमें we have from the data we have obtained उसमें जितनी comorbidities and increasing age include होती जाती है तो the chances of graft failure or rejection increases.
Okay, how many in cases of we know that those who are having keratoconus or corneal dystrophies they do get good results,
yes,
but
the most promising
with scars, with vascularized corneal opacities or with advanced glaucoma cases, the vision becomes not so good. So, which cases did you include?
We included all the data that I've already showed here. These were the reasons and these were the patients, and among them, the best and the most promising results were obtained for keratoconus, corneal scars, and congenital opacities.
Okay, what procedure? How did you do? Did you use Moria's punch or whatever for cutting this?
Yes, we use that trephine that we have to cut the cornea and then replace it with the.
What are the different types of cutting corneal the corneas? How do you cut? What are the advanced techniques? Refines which you cut because that is an old one. Now we don't use much.
I'm sorry, I'm not very well aware of the operating side yet because I'm only in the first year and I was more focused on the data collection.
Okay, very good presentation, very confident, and best of luck for you.
मैं एक तरह और ये जो क्लैपिंग थी ये स्पॉन्सर थी
नहीं सर
यही क्लैपिंग राशिद के अवार्ड पे भी हुई
Thank you for a nice presentation. ये आपने टॉप पे congenital opacities कि मतलब ज्यादा पेशेंट ये थे, जबकि बैंड क्रेटोपैथी के सबसे कम पेशेंट थे। वैसे तो ज्यादा बैंड क्रेटोपैथी के लेके जाते थे।
जी सर, इसमें हमने
ये वजह
मैं आपको बताती हूँ, इसमें हमने कोई एसएच सेट क्राइटेरिया नहीं यूज किया था। It was we tried to follow all the 218 patients we had, लेकिन most of them were lost to follow up, maybe because they were from far-flung areas. तो जितने भी करीब के थे and they were easily accessible, so we only included them, and that is why I mentioned it to her as well, that we haven't published it yet because we really want to increase the sample size and increase the frequency and the number of other cases as well to make it like a more wholesome study.
नेशनल यूनिवर्सिटीज में पोस्ट ऑपरेटिव भी क्या आपने किया उसमें या कैसे करते हैं, तो और भी ज्यादा उनके और भी डेंटल प्रॉब्लम्स होंगी।
जी बिल्कुल सर, हमारे पास पूरा एक पीड्स ऑप्थेल्मोलॉजी का अलग से डिपार्टमेंट है जो उसको फिर केटर करता है।
Can you refer the children to pediatrics?
Yeah, we have it in national.
Thank you.
You're welcome.
Very good.
What was the minimum age on which you performed?
5 to 55. The minimum age, I think we had a patient of 7 years.
My request is not a question, but just to give a comment about for the knowledge of our residents, that the patients of corneal edema caused by phaco or other procedures and the keratoconus, the penetrating keratoplasty is now becoming less and lesser indication. The better procedures for these two procedures worldwide and in Pakistan as well. Now there are lamellar keratoplasties, and a very recent treatment is what is called as donut transplant. And we don't have to go for a transplant. We just want to particularly the keratoconus. If the patient has got a clear corneas, we don't have to go for a penetrating keratoplasty. So the keratoconus is not now an indication of penetrating keratoplasty, and same is for corneal edema due to the endothelial problems. Now the treatment is endothelial graft. So the lamellar grafts are becoming more and more not only popular, but actually just as we say that not now all the cataracts, the indication is phaco, no extra cap, no infra cap, no whatsoever. So similarly now almost all the keratoconus patients and all the endothelial caused corneal edemas, the treatment is lamellar grafts, either posterior or edema. Thank you.
Thank you so much, sir. Thank you.
Okay, thank you, Dr. Naik, for your very valuable comment. And now we move on to our next speaker, Foha Ahmed. Okay, you're right.
I'm Dr. Mohammad Fazan Ahmed. This paper is authored by Professor Dr. Abdul Naik, and I'm here to present it today. So we're going to talk about a rather rare presentation we don't usually see in the regular practice. We'll be talking about crab louse infestation of the eyelashes. So actually, the number of infections is considered much higher. These lice are members of the order Pteroptera, and these are wingless, dorsal, ventrally flattened insects, but rather we can say they are ectoparasites. They are parasitized in man by two species called Pediculus pubis and Thyrus pubis. We'll be specifically talking about Thyrus pubis today. These are actually vessel feeders, and they pierce the small blood vessels and suck the blood by a group of stylets which are present within the head of the insect. So this is a visual representation. This is what it looks like. As the name suggests, they look like crabs, and they have like two. They have two heavy pincer claws which they use to attach to the hair. So the study that we're going to talk about includes 10 cases of crab louse infestations, and the purpose of the study was to present clinical features and management of the 10 patients. These are the 10 patients. There are 7 adults, which includes 5 males and 2 females, and there were 3 children. We can also see from this that there were 40% of the patients had systemic lesions as well. For example, maculae, cerebrally, and bullous lesions as well. We will see these later in the presentation. The methods used were that all of these patients were examined ocular examination was done as well as systemic examination was done. The infested parts of the body, including eyes and the other parts, were photographed. Adult patients were asked about similar problems in their sexual partners, and the parents of the children were inquired similarly, because this can be considered a venereal disease as well, and it is actually spread by close contact. So all of these patients were treated by adequate washing of the eyelashes, and the other parts of the body were also cleaned with soap and water. Polyfex eye ointment was used, and anti-lice dermal preparation was used on the other parts of the body to clear up the infection. What the ointment does is that it interferes with the respiratory function of the lice and therefore kills it. All the patients were followed for a period of 3 months, and follow-ups were done every 2 weeks. We've already discussed the results that there were 7 adults and 3 children, and 40% had systemic lesions as well. The symptoms that we see were deposits in the roots of the eyelashes, irritation or feeling of something moving in the eyelids, lacrimation, and redness as well. The signs that we see were there were multiple lice entering in the roots of the eyelashes, sucking blood, and there were hundreds of nits cemented with the eyelashes. There was conjunctival congestion, and the removal of lice resulted in ulceration at the margin of the eyelid. This is a visual representation, not quite clear here, but if you see in the center, there is this ulcer present from where the lice was removed, and these light brown colored nits are seen, which are hundreds in number, attached to the eyelashes. This is what it looks like. It looks like a crab, and it has claws that is used to attach the eyelash. Conjunctival congestion was seen in the lower lid and the upper lid as well. And these are the systemic lesions that were seen: a bullous lesion and some maculae ceruli, which is actually caused by the bite of the lice, and it causes hemorrhages in the dermis. Systemic features also include this kind of nits in the pubic region. Moving on to the discussion. The patient actually presents with itching around the eyelashes and the other parts of the body as well, like the pubic hair, axilla, and of course the eyebrows that we're talking about. It is mainly in the evening, and in contrast to the hadlouse, these are slow-moving insects. So these are another thing to note is that they are usually present in the area of the body where the hair are not very dense. We've discussed the systemic lesions already, that maculae ceruli can be present and bullous lesions can also be present. So moving on, a mild degree of nephritis can also be seen in these patients. Phylloxamine is also used in some places, but they have their side effects. And malathion are used elsewhere on the body to get rid of these lice. Some people also use the epilation of lashes to get rid of them, but that can be So I'll just conclude my talk with the emphasis that and the significance that it is not the clinical condition of crab louse infestation, not only as a venereal disease, expecting much higher number of infections, it is also an important cause of refractory cases of chronic irritation. So it should be recognized with a sweat lamp and treated accordingly. And partners should also be treated as well. Thank you.
Okay, thank you very much. Any questions from you?
एक question है. Did you examine the hair of the patients?
Yes, especially in children. In children, it can be seen in the hair as well.
Next का कहाँ होते हैं?
That's our common.
हाथ की ओर तक होते हैं.
In the hair, in the hair as well, in the scalp, the eyelashes, eyebrows.
चार में होते हैं. खुजली में ये दिखने कैसे? तो है आपको. और दूसरी बात ये है कि ये जो एंटी-लाइस शैम्पू होते हैं, उसमें क्या होता है?
Malathion.
Are you sure?
There are different kinds.
You should see yourself. Thank you.
Actually, the crab louse infests only those areas where the hair are less dense. This cannot move in the scalp. So the crab louse cannot be seen in the scan. It is only in the pubic hair that transfers from the pubic area to the eyelashes and the other parts. And so the nits or जिसको हम पंजाबी में लीखें कहते हैं, they are not present in the head in case of crab louse. It is in the eyelashes and in the pubic hair as well. And for a pic of the area where the nits was there in the pubic hairs, it is sure that it is a sexually transmitted disease. It's a venereal disease, and one must look for the other sexually transmitted diseases in the patients which are affected. Thank you.
Thank you very much. And with this concludes the session, and I will hand over the mic to Dr.
Thank you very much for your participation. Good presentation prepared and various different topics were considered, which you have followed also. And I appreciate the effort of your supervisors, those who prepared and keep it up.
From next time, every resident should know that the case studies won't be marked because there are no statistics involved in it, so you won't get any position. You can present the paper, but it won't be included in the award list. Okay, with this, close the session.